Today we are going to focus basically on roots, because this is how spherical attachment was born for this company. And in the last part, I'm going to give you a small pill with a smart solution to renew and restore old spherical attachment from every system you have. That can grant you to maintain your spherical attachment for a longer period, for a lifespan endurance. This is where we are. This is a town, an old town in Italy, Bologna, and the company was born and is still settled here in Bologna, exactly in the middle of Italy. I invite you all from all over the world to visit our town and visit the company when it will be possible, or easier, at least easier. It would be a pleasure to meet you in person, in presence. Spherical attachment was born exactly in 1983 as a pivot, as a post placed in a residual root when implants were still in the beginning. Implant rehabilitation was still in the beginning. Nowadays, they come with two series of spherical attachment. One is a small named micro spheroblock that has a 1.8 millimeter of diameter, and the second series comes with a named normal spheroblock that comes with 2.5 millimeter in diameter. And you can have different lengths, 7, 9, and 10 millimeters to match perfectly, to better match the length of your roots. Obviously, 10 millimeters is more suitable for canine, for example, and 7 millimeters is more suitable for smaller teeth as incisor or premolar. This is this kind of sphere block come out from the factory directly like this. And so they are designed to be cemented directly in the root. If you have a more a case where you want to cover the dentin, you can use the Castable pivot. And we are going to see how to use one and how and when use the other. Why today we are still talking about saving roots and placing pivot in the roots, within the roots, to anchor a prosthesis? You have many reasons to do this. I know that today, we know that today implants are available and are more reliable than in the first period. And it's a practice that every dentist can do, especially when when we talk about overdenture. But saving roots could be a choice for many reasons, for many patients, from many points of view. If we think about an economical point of view, it could be interesting to save some roots, but I want to focus some argument on why we want to save some roots. Because even if you make an endodontical treatment on this root, the tooth can still maintain the periodontal ligament. And the periodontal ligament is still maintain a function for this tooth. Because in the periodontal ligament we have different kind of receptors, and they record the sense of touch, pressure, and pain, giving the tooth still a vital function for the mouth. For the masticatory function, especially, you have three kinds of fibers of receptors. They are all mechanoreceptors. So you have three end fibers, a Meissner corpuscle and Ruffini receptor. They work exactly as they work under our nails, but they are linked with muscle tension, with the central nervous system. They are connected with the muscles, and they, in some way, they have a regulatory function for the contraction or relaxation of the muscles. It is studied that mechanoreceptors are activated by tooth movement as little as 1 or 3 microns. So they are very, very precise, sensitive instruments, sensory instruments. And periodontal ligament encode the tooth load efficiently and sends messages till the central nervous system. It is demonstrated that signals from periodontal ligament together with proprioceptors in muscles and tendons play an essential role in the fine control, regulation, and coordination of the jaw. In which way? It's very easy to explore this function, and I want to give you a demonstration. You can do this on your office, on your own. Just take a pencil, grab a pencil, a wooden pencil, and try to put it between your incisors, and try to bite with the biggest force that you can use. And you will see that your incisor will send an inhibitory message to your brain that will give an inhibitory message to your masseter muscles and temporal muscles, inhibiting the contraction of the muscles. So even though you want to use the strongest strength that you can, but your brain will stop you. This is because periodontal ligament in the incisor and in the canine are giving a downgrading message for the muscles, for the contraction of the muscles. So anti-feedback. If you do the same with the molars, you have the opposite function. I mean, the molars, the periodontal ligament in the molars will enhance the message from the central system for the contraction of the masseter muscles. So if you do this with the molars, you can destroy the pencil exactly like this. So this is a study where in these studies they demonstrated this function, and you can take a clip of this if you want. Of course, if you remove a root, you lose this function forever. Even if you put implant, you don't have any more periodontal ligament. You don't have any receptors around implant. Of course, if you extract tooth and place an overdenture directly on the mucosa, you don't have any pressure, any sensitivity about pressure. And of course, even if you have some from the mucosa, you don't have this fine regulation between periodontal ligament and muscles and tendons. Now this is the theory, and now we go to the practice, how to use a compromised root and how to make it work again as an anchor for the prosthesis. This is a very easy and easy case, easy clinical case, where the patient came in the office with this removable prosthesis. She had four clamp, and she had pain here because this big decay cracked the tooth. So I had a residual root, and my choice would be I could have extracted the tooth and put the clamp in the next tooth in the canine. But I think that I have a better choice than to put another clamp than to make another clamp, because I don't like clamp. I prefer to put pivot and the post inside the root for a different reason. First of all, I have to make the root canal therapy the best root canal therapy that I can, because this would be my next anchor for my prosthesis. So I want this to last as long as it can. And then next step is to make the post space. And when I'm substituting one crown, usually I prefer to use the micro Sphero block, 1.8 millimeters diameter, because it fits. It has more space inside the space of a crown, a single crown. So choose the right pivot that fits better in the root. And I recommend you, if you have a small root, I recommend you to do this. Instead of making a big post space, weakening the residual root, it's better, I suggest you, to make smaller the pivot. So you have more space for the dentin, and the residual root will be more solid, and it will last for a longer period. You avoid crack of the root. Once you have made the space enough that until the pivot fits perfectly passive inside the post space without touching too much the walls, the inner walls of the post space, you can glue it in. Once you have glued, you have to reline to connect the pivot with the prosthesis. And you can do this by placing a separating foil. You can use the discs that comes out with from the companies, or if you have a more complex anatomy like this, where I have the papilla here and I have the gum around the pivot to cover, I prefer to cut a small piece of gum or a small piece of glove as a separating foil, because I don't want the resin to get down here. Otherwise, the resin that I'm relining with will cure below some undercuts, and I can't extract the prosthesis anymore. Doing this, I saved a root, of course. I saved the periodontal ligament, but I made another trick to gain more advantage, instead to placing a clamp, because I have cut the crown. So my anchor point is no more here in the middle of the crown, in third medium of the crown, but is lower. So I lowered the root to crown ratio. This means that the forces on this root are smaller, and the forces transmitted to the periodontal ligament are smaller. Plus, they are not horizontal, because the clamp works horizontal, but the pivot works vertically. So it's more physiologically, it respects more the periodontal ligament. Second, you have to choose the right female cap. And I always suggest to start with the softest, the green cap, because you have to check the ability of the patient to clip and remove the prosthesis. Then you can upgrade, depending on the case, the case you have, you can upgrade with strongest retention. This is a very important slide because here you can see the difference between elastic material, right, like OTCAP, and acetalic plastic or metal with metal, rigid materials. Because elastic material, like female OTCAP, works as an elastic material. This means that once they touch the equator of the OTCAP, of the sphere, they get compressed. And once they pass the undercut of the sphere, they relax and they return to their shape, the original shape. This means two things, that the retention is due to the return, to the elastic return of the sphere, and not because of the friction. So the contact area, the retentive area, is bigger instead than a system that works with friction. And this means that the wearing rate of the elastic material are lower than the wearing rate of the rigid materials. So, and the part that gets consumed is the female part, that is a lot easier to change, or sometimes is possible to change only the female part than with rigid material. Because when you use metal with metal or rigid plastic with metal, the part that gets consumed is the metal part, the male part, and sometimes it's not possible to change it. While I'm doing my endodontic treatment and while I'm fixing the pivot in the root, in the laboratory, I send the prosthesis to the laboratory, and they are going to cut the clamp, add a new tooth, and dig the space below the tooth. They have to make a big hole below this tooth because I have to reline. Here is the hole, the space. I have to reline this one on the pivot directly in the mouth. So I need no space. I need that there is no space, no touching point, no contact point between the female cap that I'm fixing and the prosthesis. Once I have isolated with the rubber dam foil, with the disc or plastic disc, or with the glove foil, I can fill the hole that they have made in the laboratory with resin, and then fix it in the mouth. I ask the patient to close and keep it closed tight until it is completely cured. I can check also, I can take a reference point before ask the patient to close, so I can check that the contact is reached, that the contact is reached, the vertical dimension, the original vertical dimension is respected. And then I have to wait until the resin is completely cured. Otherwise, I don't have the perfect engage between the female cap and the prosthesis. So once it is perfectly cured, I can ask the patient to open the mouth and remove the prosthesis. Then, once the prosthesis is completely removed, I have to clean the resin that can touch the root, because if the resin touches the root, I have rigid material on rigid material, resin on root, and I don't want this, because my prosthesis will lay on mucosa and on rigid material, on a rigid material. So I have to avoid the contact between the hard part, this one, and the root. After that, I can give the prosthesis to the patient and check that she or he is able to clip and remove the prosthesis by herself. So she was very happy because she didn't put a clamp in a more visible area, like in the lateral incisor. And she still was able to use the old root of the tooth. So we saved one root. After 1 year, something similar occurred in the mandible. In this second molar, because of a decay, here you can see the decay, the big decay, the tooth was not more disposable for was not more reliable for a clamp because of that decay. So we cut the crown and we used the root to glue in a pivot, and made the same exactly the same protocol. And in the end, it ended up in the same way, with no clamp in a more visible area. And the lower prosthesis is anchored also with the OT-cap. Since she liked a lot this kind of protocol, this kind of system, she asked to do the same in these other tooths. So she were allowed to eliminate completely the clamp. We still maintained the tooth, and we used just the root to anchor the removable prosthesis. This case started as a first aid with this tooth, but ended up in a rehabilitation, and complete rehabilitation, with a very simple and cheap and easy technique. That was a partial denture, but you can do the same with a complete overdenture. In this case, for example, we have a residual canine, 2 residual canines. We cut it, and we made exactly the same protocol. First of all, endodontic treatment, and then glue it in. We glue it in the pivot. In this case, in particular, we have one more advantage, because when this patient had his removable prosthesis, the occlusal plane was made by resin teeth, and natural teeth. So they worked differently, because we had resin and enamel or dentin working against the upper prosthesis that was completely in resin. So the wearing rate of the upper prosthesis was different, because these 2 natural teeth made 2 holes in the opposite prosthesis. Since we converted these 2 canine into 2 roots and into an overdenture, a complete overdenture, we standardized. We have only resin in the occlusal plane. So the antagonist can occlude only with resin. It's more uniformed occlusal plane, and this is very important. Plus, we have, of course, all the things that we said, the advantage that we said. We have lowered the root to crown ratio. So instead to putting on a clamp on it, we are working on a lower level. So the cantilever and the forces developed on this root are lower. This means that this root will last for a longer time, of course. And this prosthesis anchored on these 2 roots will still have some sensory and masticatory function, because this periodontal ligament will give that message, pressure and mechanical message, to the central nervous system. So we fixed 2 pivot inside the root canal, and here you can see in detail how to cut the root. You have to follow the shape of the ridge of the residual gingiva. If you have this shape, you have to make like a bevel, a very big bevel, to follow this shape. Otherwise, you will have a very sharp, very sharp angle here, and you have less space for the resin in the prosthesis. Of course, you can do the same for the upper prosthesis, and here you can see the 2 the two female cap inside the stainless steel housing. And again, with a very cheap and economical intervention, we made this prosthesis more stable, more fixed, and easier to maintain, because she only had to clean with a brush two root, for root for pivot. Now we have another situation where we wanted to save this tooth with a castable pivot, and we are going to see how to use these. We started from this point. As you can see, we have mixed denture. So we have resin teeth, natural teeth, resin teeth, natural teeth again. And this is what I was saying before, where we had natural teeth like this. The antagonist prosthesis went under a wearing rate very rapidly. Where we had like this and this, where we had natural teeth like this, the resin in the counterpart was worn out very rapidly. So we had an occlusal plane like this, a zigzag occlusal plane. So it's better to make an uniformed occlusal plane, made all by resin or by teeth, never mind, but it must be uniformed. So this is the starting point in the maxilla, and this is the starting point in the mandible. First of all, we have to make some order inside. So first of all, we check with the wax wall, we check the occlusion and try to find a natural position given by the temporomandibular joint, because teeth were not more a referment point. With the wax wall, we can check the horizontal plane parallel to the papilla, to the pupilla, to the eyes, ball eyes, Frankfurt plane and Camper plane. We are going to check them also with the Fox plane and the wax wall. Then, after extraction of the teeth, we start with not extraction, but root canal therapy first of all, and then not extraction properly, but crown cutting after the proper root canal therapy, because we have to do the best root canal that we can, following the root canal endodontic protocol. And then we can cut the crown. We have to follow the shape of the gingiva, of the mucosa. We save the teeth with one or two root canal, and especially the teeth that give relaxation, that whose periodontal ligament give relaxation for muscles. So I don't want to use molars, because periodontal ligament in molars, they give a message for contraction, for more contraction of masseter muscle and temporal muscle. So they are ready for taking the impression, and I take the castable pin, the plastic pin, make some physical retention, like some scrap, varnish with the adhesive for the impression material system that you are using. If you use polyether, you have to use the adhesive for polyether. If you use polyvinyl xylosane, you have to use the adhesive for that. And then place the pin inside the root canal that you are going to save and use, and take the impression, in this case, polyether, in the maxilla and in the mandible. So you have the two impressions with the post space right here and the sulcum around the teeth, because I have used the double floss technique. After that, you check with the wax wall, with a complete wax wall, and you can put all the data in the articulator. With this data in the laboratory, they can provide a wax wall with teeth that I can check in the mouth, right in the mouth. So this is the wax with teeth mounted, and we can check the function, the vertical dimension, the aesthetic with the patient directly, because designed in this way, it has a better suction and it is very stable and in the mouth. So the patient has a perfect vision of the final outcome of the prosthesis, how it's going to look, and we can check the phonetic, of course, and the aesthetic and the final aesthetic. In the lab, with the impression that I've made, they made a cast, of course, and they placed the pivot inside the root. When you use a castable system, the biggest advantages that you have with castable system is that you can place the ball attachment in a different place, different from the axis of the root canal. If you use prefabricated one, you have to put in the in the middle of the root canal. So the position of the pivot is established by the position of the root. With castable pivot, you can move it in another place. So if it's in you can put it more palatal or lingual, where it doesn't interfere with aesthetics or function. And more of all, especially, you can put it perfectly perpendicular to the occlusal plane. This means that it can last longer, because if you check the occlusal plane, if you take it as the horizontal plane, then with the parallelometer, you can put it in another place different from the center of the root canal, and then you put it vertically. And it's important, because when you give the patient a denture, he put it in the mouth and he close. It's difficult for him, for the patient, to follow a pattern of insertion, a particular pattern of insertion. It's easier for him to do it vertically. And during the masticatory movement, the prosthesis move in a vertical way. So if you have a spheroblock, a ball attachment, a spherical attachment that is not perfectly vertical, perpendicular to the horizontal plane, to the occlusal plane, it can worn out more in one side than in another. After the casting, you have the pivot perfectly polished, ready to be glued in the mouth. After gluing it, I have to take the impression of this pivot, because the laboratory doesn't have the position. So I'm taking the second impression with this kind of transfer coping, and they must be coupled with this analog to make the cast. After that, I take the second impression with the customized tray, impression tray. Here it is. And then in the laboratory, they can fix the analog in the female cap, in the transfer within the female cap. And then in the lab, they can start assembling the structure of the denture, just by cutting and assembling the pieces together. It's a very easy, quick step. They assemble just together and put it in the oven for the casting. After that, fixing the female cap, elastic female cap. And then we have the denture, complete denture, with a framework inside, so is more solid and durable. And this is the X-ray check after 2 years. And this is how it looks. The last argument I want to talk about is how to make this spherical attachment last for a longer period, because everything goes under consumption. They are used a lot, and many patients have received implants in the past years. So these are data that I gathered from different funds. If you count that how many people have implants in their mouth, it's easy for you to encounter the new patient with implants in their mouth, and you have to face this new scenario of patient. So we are going to have patient with implant placed in the past decades. Your next patient maybe has implants with spherical attachment, old spherical attachment that you don't know. And we have to face with new mechanical pathologies, like implants part failure or prosthetic failure. And we need new tools and new instruments for the maintenance and or the renewal of old component of the prosthesis or the implant. Sorry, one way with which you can renew old prosthesis is to use the reconstructive sphere. You can have two kinds of reconstructive sphere. The first is the solid reconstructive sphere. You have the ball attachment, spherical attachment, niturated. This means that the coating of this attachment is made with a special treatment that gives more hardness until 1,600 Vickers of hardness. It's a very strong value. This means that it lasts for a longer time. You can the solid reconstructive sphere has a pin that you can fix in different situations. This is the kit that you can find in the in the company, in the catalog, and you can fix it in different manner. For example, this is a crown, an old crown with a ball attachment that was completely lost. And of course, the removable prosthesis hadn't any clip anymore. What to do? The alternative is to do everything completely new. So do a new crown with a new attachment and a new removable prosthesis. It's a big treatment plan, expensive for the patient. But if you have this small solid reconstructive sphere, with a very simple intervention, you can renew, make it completely new. Just check that the pin is inserted completely inside the hole, and then glue it in and reline the old prosthesis, make a hole inside here, and reline with the same technique that I showed you for the root, reline the old prosthesis with the old system, renew it with the OTCAP reconstructive solid sphere. Another situation, this patient came with this 6 old implant. I completely didn't know what implant was under every abutment of this. I didn't know, the patient didn't know, they were very old implant, but the patient needed a solution, and I found that the solid reconstructive sphere fitted perfectly in these three implants, in these three abutments for these 3 implants. So I glued them. I glued the solid reconstructive sphere in these holes, and then relined the old prosthesis that the patient had. So with a very small trick, we had the complete satisfaction of the patient. Another situation, this bar worked with friction with the counterbar, but after some year, after the years, passing the years, the friction was completely lost. So the counterbar didn't fit enough with because it was metal to metal friction. It was perfect in the beginning, but after some years, it didn't work anymore. So we made a hole in the bar with the help of the lab. We made a hole and then fixed the solid reconstructive sphere inside the bar. And in the counterpart, we made the hole to fix the female cap. The second solution to renew and make and give a new life for old anchor spherical attachment is the solid hollow reconstructive sphere. Is the same treatment. It has the same treatment, so it's nitrurated titanium nitrate in the surface. This coating gives a hardness, more hardness than the titanium alone, or metal alloy alone, but it is hollow inside. This means that you can glue it in over to cover old worn out attachment. And you can have in three dimensions, 2.5, 1.8, and the smallest is for CAD-CAM system, for the CAD-CAM system. So you can use, if you use that kind of system, you can still use that kind of OT cap, that kind of female cap, sorry. Otherwise, you can convert the old system with the OT cap system. This is the kit that you have, one handle, because it's very small, you have to put it inside here and use it with the handle. So this is the female part, the male part, sorry, it was golden. It was an old ball attachment glued inside an implant. And it was completely worn out. It was no more a ball attachment, it was a cylinder. So what you have to do? You have to do. You have to dig to scrap the what remains of the ball attachment until the new hollow reconstructive sphere perfectly fits inside. So make it as small as the hollow sphere can cover and can arrive until the end of the course here. Once you have checked this, here you can see it in a better way. You have to dig the old spherical attachment. You have to scrap it with a burr until it fits perfectly inside the hollow sphere. Then you can glue it in. You can put the glue, anaerobic cement. It's a self-curing cement that cure in absence of oxygen. Then put it, remove the excess of the resin, and then you have a completely new attachment, ball attachment. Otherwise, you had to find the way to unglue this from the old implant, find what implant was that, and find the new attachment. A very long and time-consuming procedure. With this system, you have renewed it immediately, and then you can reline the old prosthesis with the system that I showed you in the beginning. So put the foil. In this case, I recommend you to use the glove because a rigid disc can't be applied to follow the shape of the abutment. Use the glove and then place the female cap. Then, if you have enough space, place the steel housing, and then fix the prosthesis. With this, I have finished. I thank you. I hope that it was interesting, and I am available for question, answer. If you want to talk with me, I'm here for some minutes more. You can write in the question and answer here. Okay. Okay, I think that we don't have any.
There are many participants who are thanking you.
Okay. I see. I'm looking at the chat. Thank you, colleagues. I really hope you to meet here in Italy or to come in your country. We used to travel a lot to visit colleagues around the world, and it's a very
There is a question.
Oh yeah. Okay. Okay, I see.
Is sphere better than equator?
It's different because if you use the sphere, you can, in the long term, you can renew with the reconstructive hollow sphere. If you use the equator, you can't do this. So it depends also on how much space you have. This technology in CAD-CAM, yes, you can. When you make a bar to lock implants, you can put it. You can in the digital plan. You can put it in the bar. You have a spacer, a digital spacer, when you are in the CAM program, and you can put the sleeve with the Spherical block directly in the bar. So with the CAD-CAM, you can make the space in the bar for the sphere. Good, dear colleagues, I say hello to everyone and hope to see you for the next webinar or in person. Bye-bye.